Welcome to Medscape. I'm Dr. Andrew Wilner reporting on the American Epilepsy Society meeting. With me today is Dr. Olga Taraschenko, Chief Comprehensive Epilepsy Program, University of Nebraska Medical Center. We will discuss her paper where she reviewed the association between anti-seizure medications and movement disorders. Welcome, Dr. Taraschenko.
Thank you for having me.
Thanks for joining us. So I picked your paper because I thought it was pretty interesting. I remember way back, seeing patients with phenytoin and nystagmus and ataxia, right? We always look for that every clinic visit in the epilepsy clinic. But it seems you found a whole lot more of association with anti-seizure drugs. They used to call them AEDs. I'm probably going to say that at some point. Now we call them ASDs, right? Anti-seizure drugs.
Anti-seizure drugs.
And so tell us how you got interested in this and what you found.
Yes, so the idea of conducting the search in the literature came from one of our residents, Dr. Danzu, who rotated a lot with the epilepsy team. And he was curious about these frequent side effects that we observe both in the clinic and in the epilepsy monitoring unit. It's new onset abnormal movements. So we decided to conduct a systematic review of literature in collaboration with our librarian, and we did a comprehensive search. We searched all available databases from inception until the last year. We came up with about 5,000 records, and then we applied our inclusion criteria. Specifically, we were interested in new onset movement disorders, which were linked to particular anti-seizure medications. We included all anti-seizure medications available on the market. We also recorded the data on average daily dose whenever it was available, as well as serum levels, if they were measured, and also remediation steps that were taken to alleviate those side effects. As a result of this application of inclusion criteria, we came up with over 250 papers, which were mostly case report and small case series with 5 patients and less, as well as 45 manuscripts, which were focused on comprehensive randomized control studies and cross-sectional studies.
Well, how do you know that these movement disorders were side effects from the anti-seizure drugs or not, or just some concomitant finding?
Right. So in this project, by design, we had to rely on authors' determination that actually there was a temporal relationship between the initiation of anti-seizure drug and also resolution or at least improvement of the symptoms with discontinuation. We took note of other concomitant conditions which could present with abnormal movements. However, we only had a handful of patients with underlying Huntington, chorea, and Parkinson's disease. There were not too many patients. And we also actually looked through the papers just to make sure that we agree with determination of the authors. But of course, it's a retrospective kind of study, it's a systematic review. So potentially there may be a room for bias.
So I'm imagining a kind of gigantic Excel spreadsheet here. So we've talked about phenytoin. What was the number? Was that the number one drug that was associated with abnormal movements?
That's exactly right. Phenytoin came up most frequently in the literature. First, we thought it's because phenytoin is an older drug and has been on the market for a long time. But even among older first generation anticonvulsants, phenytoin clearly took the lead. And we found primarily chorea and erythrosis, as well as eye movement abnormalities that, like you mentioned, nystagmus, ophthalmoplegia, and even opsoclonus, myoclonus in association with phenytoin. We also, as you said, in that large spreadsheet, we had carbamazepine and valproate. Valproate frequently came in association with Parkinsonism, but even newer anti-seizure medications that we think of as being safe and well tolerated came up in the search, and we saw a lot of eye movement abnormalities with lamotrigine, as well as orofacial dyskinesia and restless leg syndrome with topiramate.
Wow. So phenytoin was number one, and then carbamazepine, and then valproic acid, and kind of like that?
Pretty much based on the kind of the bulk of the literature that was available, but we were also surprised by high number of reports on myoclonus in association with gabapentin and pregabalin. And interestingly, about half of the patients who presented with this, for whom the levels were available, and also some other labs were available, had abnormal creatinine, abnormally high creatinine. So the clearance of the medication was clearly affected. And so in this settings, they presented with myoclonus. So that was a frequent flyer as well, gabapentin.
Yes, the first case I saw like that was in the dialysis unit with many of these patients are on gabapentin for peripheral neuropathy or something like that. And this patient had really dramatic myoclonus. So I had to look it up. And now, I guess every few months there's another patient in the dialysis unit that has myoclonus. That's a kind of a pretty standard neurology consult now. So I think, this really helps in that if a patient who's taking a seizure drug develops a movement disorder, your first reflex shouldn't be to do an MRI scan, right? It should be to think about the medication and see if there's some temporal relationship. And maybe was it usually dose related also? You mentioned with gabapentin it's with a high creatinine. Was there usually a dose relationship?
Not so much. The doses which were actually listed were quite modest. For phenytoin, I think the average daily dose was in around 400 milligrams, which is quite modest in the epilepsy world. And the doses of lamotrigine were close to 200 daily, which is very actually a tiny dose for somebody who has refractory seizures. What we've noticed, so that at least for phenytoin, the serum levels mattered. So for some reason, half of the patients had supratherapeutic level, and that seemed to somehow was related to the development of abnormal movements.
Was there any sort of inverse relationship? For example, alcohol can suppress tremor. Did you see any sort of effect of the anti-seizure drugs that are actually reducing pre-existing abnormal movements or being beneficial in some way?
Well, we didn't particularly look at that, but we were surprised to see that even medications that we use traditionally to suppress abnormal movements, such as diazepines and phenobarbital, came in several reports in association with abnormal movements. So that was quite a revelation. And clearly, the authors were convinced that the drug was a culprit, not something else.
So you're making an argument, I think, for personalized medicine because patients may respond quite differently to the same anti-seizure drug. Is that right?
I think it's a very interesting idea. We clearly don't know the pathophysiology for the majority of these side effects. We do know that there is valproate-induced Parkinsonism that interferes with the GABAergic neurotransmission in the basal ganglia, and some other receptors are being affected by gabapentin, and that results in myoclonus, but we clearly don't know what's causing it. I think it does make a lot of sense to pay attention to individual comorbidities and also co-administered medications. As we know, some other drugs such as antihistamines or antidepressants can precipitate it independently.
Now you mentioned Parkinsonism could be worsened by valproic acid. Are there any other sort of clear-cut relationships where you might want to avoid a particular epilepsy drug?
We didn't see any other clear particular comorbidities. We didn't take note of them in this study. There were a few patients with Huntington chorea and Parkinson's disease, but really, I think it would make sense to avoid drugs that frequently came up with acral dyskinesia or myoclonus in patients who already suffer from abnormal movements in their extremities that interfere with their daily activities, such as, for example, hand myoclonus in gabapentin, or even restless leg syndrome with topiramate, association with topiramate.
Now, one of the risks of using antipsychotic drugs is tardive dyskinesia, which can be permanent. were these movement disorders related to anti-seizure drugs permanent, or were they just kind of temporarily related to the dose?
The majority of side effects resolved following either cessation or adjustment of the dose, with two exceptions being phenytoin and carbamazepine. We've seen with phenytoin only about 80% resolved completely, but only 20% improved. So, and it did take quite a while for phenytoin. Most patients had to wait about 3 weeks to get better. Which was quite actually interesting. The literature was not so impressive. I mean, we just didn't find too many reports for newer medications, but for the large majority of the side effects, they were reversible with discontinuation of the drug.
One more question, and this may not have been reflected in your study. Were you able to associate any of these movement disorders with seizure or epilepsy type? So, for example, patients with generalized epilepsy or focal epilepsy or temporal epilepsy, were they more or less susceptible to a particular drug, or did that not sort of filter out of your?
No, we didn't take note of the epilepsy syndrome. I mean, as you can imagine, sifting through cases and case reports is a rather tedious task. So we were happy to extract the information that we were aiming to get. We did not separate them, but one of the future projects that we are thinking is to focus on abnormal movements in patients with refractory epilepsy, pre-surgical or even surgical epilepsy, patients at our center, and retrospectively look at their charts and see if there is anything about polytherapy and perhaps separating the syndromes that way.
Well, and of course, pre and post surgical cases would be interesting also. If the movement disorder disappears when the when the damaged brain is extracted, that would be certainly of interest. Well, Dr. Taraschenko, this has been great. Thank you for sharing the results of your paper that was presented at the American Epilepsy Society.
Thank you for inviting me.